this Monday Roundtable edition on the Compliance Guy. So good to have all of you tuning in, logging on, and just hanging out with this all-star panel for a little while. Joining me today is Paul Spencer, Christine Hall, Terry Fletcher, Stephanie Allard. I am so grateful for you all being here today. We got a lot to talk about and not a whole lot of time to get there. So we're going to jump straight in. And Christine, I want to start with you because I think there's a lot of misperceptions around what triggers an audit, right?
Absolutely.
And I think there's something really interesting that some practices are throwing out there, such as, take it away.
So I got a phone call on Friday, new client, and they said, hey, we just got this letter from CMS or actually from the MAC, and they're going to send us an audit. And I said, okay. I don't know why they're sending us an audit. We have the most amazing providers here. And I said, I'm sure you do. And we have great Yelp reviews. Wait a minute. That really, I got nothing to do with the Target Probe and Educate audit that they received. So there really is. There's this huge misconception as to how audits originate, how audits are how they select people for audits. It really has nothing to do with your Yelp reviews or how many patients you have or how great your HEDIS scores are or any of those things. There's always such a misconception when it comes to the business of medicine, and what I think providers don't always see what it is they're signing when they join those contracts with payers. It has nothing to do with your license, your reputation, your Yelp reviews, how many patients you have, how much your patients like you. They're looking at your billing habits. They're looking to see what are your reimbursement habits. It's
so wait a minute, Christine.
Do with that.
So wait a minute. You mean that because I have a 5-star rating on Yelp that I'm still going to get audited? Why would they audit somebody with a 5-star Yelp review?
I know, right?
That's not fair.
But you're billing the impossible day.
Paul can't even breathe.
You're billing 60 visits in an 8-hour period. Or even better, you have a modifier 25 on every patient that comes in the door, right? So there are these red flags that happen in billing that cause you to get your audits. Crazy,
oh my
right?
gosh. Okay. I don't even know where to go with this. I mean, in all sincerity, folks, listen, here's the deal. Yelp has nothing to do at all with whether or not you're going to receive a payer audit, okay? Whether your reviews are 1-star or 5-star, whether you have comments that say Dr. Terry Fletcher is the greatest proctologist in the world, or they say, I mean,
you had to pick that specialty, didn't you? You're such a tool sometimes. Oh my gosh. Yeah, Sean is actually a brother. Yeah, yeah. That I want to just flick sometimes.
So let's get serious for a minute. I got to try to wipe the smile off my face because it's just so hard. So if it's not Yelp that creates interest by the payers in auditing a physician's practice, what is it?
Well, like I was saying, it's that impossible day. You're reporting 60 visits, an hour a piece in a 24-hour period because you're utilizing your mid-levels, or extenders or QHPs or NPPs or whatever you want to call them. And there's nothing wrong with doing that when it's done right. And I just did a webinar over the weekend where we talked about incident 2 and split and shared visits and where it's appropriate, where it's not appropriate. Slapping a modifier 25 on everything, slapping a 59 on everything, having modifiers that you don't even need to be slapping it on, or having your diagnosis that don't point in the right directions. Oh my gosh, I had one recently. I have to share this with you. So primary diagnosis, tobacco smoker. Secondary diagnosis, insulin user. Third diagnosis, diabetes. Fourth diagnosis, impacted cerumen. They did an ear lavage for diagnosis A, B, and C and got denied. I don't even know. So yeah, it's things like that that I think that because, let me get on my soapbox for just 1 second. We forget about the compliance program. We don't do our own internal audits. We're not watching what the OIG work plan is. We're not looking at RAC. We're not looking at all of the agencies that are screaming at us what they're looking for. And then we get these notices in the mail.
Right. Listen, you brought up ear lavages, and I just have to tell you all, so my wife's always griping at me that I don't hear what she's saying. And I've tried to explain to her that that's referred to as selective hearing, but she didn't want to believe me. So she got me this thing called Ear RX. Have y'all seen that thing advertised on TV? Okay. It's a crock. I tried it, and let me tell you something. I had to take Debrox to unclog my ears. So, yeah, I wasted $39.99, or my wife did anyways. $39.99 on an ear lavage. And I was like, are you kidding me? Now I'm going to have to go to the doctor and figure out, did I create myself deafness or something?
Yeah. On a side note, I do want to watch one day the guy who had an ear lavage for tobacco use and how he actually smokes a cigarette. I think it would be very instructive.
Okay. So we're going to move on from that one, and let's go to what happens. What happens when a practice receives a letter? Stephanie, I want to go to you. What happens when a practice receives a letter or 2 or 10 and they ignore them? What's the problem with that? I mean, can't you just click your heels like Dorothy on Wizard of Oz and they go away because you're going back to Kansas? I mean, am I missing the picture or something?
Yeah, so this is an area, to begin with here, I have so many different comments that are made by different clients about how they handle their back end in the AR. Terry, that wasn't a reference to you. So when we think about AR, first of all, the whole entire
Are you kidding
claim
me right now?
process- Sorry. The entire claim process, everyone likes to forget about AR follow-up, right? I've actually had some clients talk to me and say, well, we're having issues with a particular practice because they don't like to do AR, so they let it sit. And some will work it once every quarter, once every 6 months, which is just pure insanity. But what ends up happening is when you have different staff in place who will just say they work the denials or post the payments or things like that, not everybody is educated to the point or aware of what these different letters look like that are coming in. So I have a couple different client situations that are happening right now. One of the clients has received a minimum of 6 different letters. They're continuing to come in. I got more that were emailed over the weekend. And each of the letters have a date. And that date is kind of your starting point, because when you see instruction in a letter that says, 30 days from this date, you have to do that, or you have to respond to us within 15 days. If you miss that deadline, it's go time. Basically, you are going to be behind the ball. What's going to be happening with one of the situations that I have right now is that the client is going to have to go through a recoupment process for some of the encounters that they've already voluntarily refunded. So this was a situation where additional communication needed to be had after the fact with the MAC, and now it's going to be this catch-up game on some encounters. Other patient encounters we haven't addressed individually yet up to this point. But this is something where it's not, if you look at the dollar amount, for example, of the individual letters, some of them are small, some of them are $90 or so. But when you start to look at the fact that these are continually coming in, and the fact that it's an extremely large practice with hundreds of providers, this is going to be an issue. The other scenario that I have going on is a a payer, a commercial payer, who's targeted one practice out of many practices. And this particular client has really been looking to grow their organization. They've been acquiring a lot of smaller practices. And one of the issues there is that everybody likes to continue to act as if they're their own private practice, right? They don't want to come in to the organization. They don't want to look at things differently. And they've ended up with a letter that was never looked at since August. Well, since there was no response, the payer's now asking for notes on every individual claim, and a lot of those are coming back denied. So we may have an opportunity to go back and fight against individual encounters, or it may be a problem where the provider really is in the wrong. They've missed out on education for all of these months, and we have to worry about the fact that this is one practice out of many.
And Stephanie, let me piggyback on that. Now we've just taken resources and put them on this new project. So outside of the entire cost, we've added additional employee cost, employee time to do this research, to file these appeals, to work these claims, that all of this could have been mitigated with opening a letter, answering it timely.
And not to mention, on top of that, having to send the notes out initially and then wait and see that nothing's paid. You know, how many times, I'm sure we all have this, when we have clients that don't have a coder involved, it drives me nuts from a compliance standpoint, but the practices are so worried about getting claims out in 24 hours, 48 hours. But what happens when, you know, you're not getting your payments turned around within a week or 2 weeks? There's a huge stopgap when this is one of your largest payers.
So real quick, Betty posted a message that I agree with her 100%. Look, staff not bringing a letter to a manager or to a department head because they're afraid that they're going to get in trouble. Again, I go back to the old adage, and I go back to the saying that I tell people all the time. It's not committing the crime that gets you sent to prison. It's the cover up. Okay. Hiding a letter indicating that you've been audited or that you have a demand for overpayment refunds to a payer, that doesn't mean you did something wrong. Paul Spencer works with me almost on an hourly basis every single day addressing insurance companies. I mean, we talked about this. Didn't we talk about this last week, Paul, with an insurance company that will not mention their name? But I mean, it was like Larry, Moe, and Shemp were on the call, and it was like the blind leading the blind. You couldn't get a straight answer from them. One individual said we did a statistically valid random sample. The other said, well, there was no actual statistical sample because the 11 patients was the entire universe. We didn't extrapolate, but then another person on the call said, oh, we extrapolated, but we extrapolated for future payments, even though they never billed us yet. I mean, folks, just because you get a demand for overpayment from an insurance company doesn't mean that you actually owe them the money.
Yeah. Let me piggyback on something on there real quick.
Go ahead.
I know that we're talking about what Christine said and what Stephanie was saying. We're talking about this correspondence that comes in. And I think what's really important with this correspondence is that, and again, I'm going to go back to your compliance program. You don't a lot of practices do not have a point person. You've got somebody who opens the mail. Hopefully that's not the same person who posts the money. That's a little suspect. But you also have people that when they're opening the mail, they think it's junk mail. A lot of these things don't look like it's, official correspondence. So you have to have somebody that knows what they're opening, understands where it goes. And I'm going to take it a step further, knows what department needs to have it, the point person that needs to have it, and then follow up that did it get handled. And that should be, again, part of your compliance program, because I have seen, like Stephanie and Christine were saying, and I know Paul's seen this, of these letters just being stuck in a drawer. We come and look at everything, and all of a sudden we find, well, this is why you're not getting paid for this payer. They didn't shut down payments for you. They're waiting for you to respond to an additional documentation request or to a denial you got. And I think one of the things that's a problem is that there's nobody that takes responsibility for that correspondence action. And so it's something that you just like who's posting payments, who's entering codes and charges, and who's doing the follow up. There has to be somebody that's in charge of mail correspondence, email correspondence. I know that's more, and then where it goes and funneled it. And that person also has to be responsible on follow up, because I see offices all the time. I have a really big client that does this, and there's over 100 physicians, and they said, oh, we get stacks of these daily. And they said, oh, we're really good at doing this and that, and and funneling it. And I said, well, who follows up? She goes, with what? And I'm like, okay. So when you hand it off to somebody in your collection department or in your medical records, let's say, or whoever you're handing it off to, do you have a log? Do you have some place and say, okay, now you're going to that person to see if they were timely? Because all these things usually have a time limit on there. You have to respond in an X number of days. And they're like, oh, well, we didn't add that piece. We just know that once it's off my desk, then I've done my job. And I face plant. So you have to have somebody that, you guys, there's a reason it's called revenue cycle management. You have to know the cycle part of that. And Paul, I'm going to throw it to you because I'm sure you see that too.
Well, we just got an excellent comment that I actually want to address, and it has to do with Medicare risk adjustment data. We're hearing a lot of anecdotal evidence that the volume associated with these requests coming from Medicare Advantage plans has been increasing, not just incrementally, but dramatically, to the point where asking for medical records from practices is becoming an onerous task. And understand that a lot of these activities, when they're requesting medical records, a lot of, whether it be for Medicare risk adjustment, whether it be for audits, particularly with your commercial carriers, like Medicare and Medicaid rules are what they are based on the state that you're in. But when you're dealing with commercial carriers, and particularly Medicare Advantage carriers, as far as the volume of requests that they have, you better take a good look at your contracts, because in most cases, what they're doing is they are putting in language that basically says we have a right to go back or a right to request documentation at any time, and they don't really put limits on that. If you have such a stipulation in your contract, before you put anyone's signature on it, you want to make sure that you can get reimbursed for the production of those records at a reasonable rate that takes into account the amount of, really the two words that come into play are hassle factor. How much of an administrative burden is this going to be when you get your records together and you have to send it out to a carrier? And just one last point, basically about handling mail. This, I don't care what the size of your practice is. Annual compliance training can take care of a lot of this.
No, I was going to say that, Paul. I was going to say, sorry, Sean. I was going to say how those correspondences should be addressed in your compliance program should be part of your annual compliance education, new hire compliance education. We shouldn't be at this point in time, 13 years after the Affordable Care Act, we shouldn't be sitting here going, what do we do with this letter? Right. So.
No, that's a great point. But let me share with you some other facts. Okay. So Kelly, your question is such a great question, right? When it comes to trying to figure out how you're going to comply with all of these requests, what I've started doing on behalf of my clients is I will actually call the signer of the letter that has been sent by the risk adjustment company, and I will let them know that their request for 300 medical records is absolutely egregious. It is not something that our practice can comply with reasonably, because we don't have the staff, we don't have the resources, and we are not able to put aside patient care so that you can increase your ask for compensation from the government. So the last one that I had, what I agreed to was, look, you asked for 100 medical records. We will give you 4 times a year, 25 medical records at a time. And they took it. Now, what was interesting was, he did not understand that this was an HCC audit. He goes, no, this is not an HCC audit. Paul, do you remember this? He goes, you don't know what you're talking about. This is a risk adjustment audit. And I said, what? That's what listen, buddy, I don't know where you got your education from, but you should call that place and ask for a refund because it has not worked.
We say, bless your heart.
So, yeah, bless your. Yeah, well, I don't say bless your heart down here in the South because too many Southerners now know what that means. And my days of, fighting are over. I'm a lover, not a fighter. So here's the deal. And by the way, and I'm sure Terry we'll get to talk about this tomorrow on our podcast as well. But I got to hang out with Terry for just a little while in Arizona last week at the NSCHBC conference. Try saying that 10 times. And it was an absolutely, from what I've heard, overall fantastic conference. But it was really great to be able to see Terry in person, and to kind of hang out for just a few minutes and then do my my little thing and then get out of there and head back to Atlanta. So Terry, I know you got a lot that is on your mind, so let's have it, my friend.
First, I wanted to shout out to you, Sean. Okay, so listeners, this is really funny. So Sean was delayed in that FAA grounding of all the flights, so on Tuesday. And so it took him forever to get to Arizona from Atlanta. Well, he kept getting pushed in his flight. And then I keep getting a text from him going, I'm trying to get there, man. And then he says, I finally get here. And he sends me this Delta letter. And apparently somebody on the plane was unresponsive, too much to drink. Remember that you shouldn't do that when you go up in the air. And Sean was the medic, but apparently Delta only thinks your life is worth $150 in credit. And so that's what Sean got. But then on the way home, he texts me when he lands. He goes, you're not going to believe this. And you were on a standby flight, right? And it happened again. And then the second time, that person's life was definitely not worth more. He only got another $100. And I'm like, he wasn't even on his scheduled flights. And he's out there saving lives across the country both days. Yep. I'm like, that doesn't even happen. It's just crazy.
So,
oh my gosh.
Yeah, so I want to be honest. I know some of you are going to think this is kind of crappy. But,
It's not.
my days of doing medic work, was a long time ago. And so when the call came over to PA, they said, is there a physician or a nurse or healthcare professional on board? And of course I'm thinking to myself, oh, crap.
No, yeah.
And I start looking around, hoping that somebody else was actually going to get up, and nobody was getting up. And they called again. We need a physician immediately, or a nurse, or a healthcare professional. So I said to the guy sitting next to me, I got to get out. And I went to the front of the plane. And unfortunately, this woman was unconscious in the restroom. And long story short, we checked her blood sugar. It was down to 60. Her blood pressure systolically was down to like 68, 69. Her respirations were right around like 56, 57, something like that, whatever.
She drank
yeah, she was severely dehydrated. She had, in 2 hours, she had a few whiskey and Cokes, up in first class. And just because you're in first class doesn't mean it's a better class of people. And, but yeah, so when I landed, I had this nice letter from Delta thanking me for rendering medical care. All I did was shake her. No, I'm just kidding. We did a lot to get her back to the living, and she was okay. But here's the thing that drove me nuts. The pilot came on, and he's talking to the flight attendant, and he's like, "Look, do we need to divert?" And I said, you tell him to keep flying straight to Phoenix. I will keep her alive until we get to the gate and then EMS can take her
Ever
off.
since the Buffalo
I have
game,
already been
everybody wants
delayed
to
8 hours
cardiovert.
today.
I know everybody wants
Yeah.
to cardiovert. People like, people don't do that.
Yeah.
But
Yeah.
anyway, thank you, Sean, for
So
saving
yeah,
lives
so
in the airways.
so Delta sent me this letter, and basically, so here's the message: if you fly Delta Airlines and you pass out and you require emergency medical care, your life is only worth about $150.
$150. Yeah.
Now on the flight home, again, they called for emergency personnel, and I was like, "You got to be kidding me, man! This wasn't even my flight. I just want to go home." So sure enough, they're like, "Could you please press your call button?" So ding, and the flight attendant comes back, and she's like, "Hey, one of our flight attendants passed out. Can you come up front?" And I was like, "Yeah, let's go." And long story short, I get up there, and it's this young man, and kind of, got him to start coming around. He was real lethargic, not speaking right, this and that. And I told him to go get me the kit, and he explained to me that he ate Panera about 35, 40 minutes before he got on the plane. And he was having issues, as you can imagine, with what comes from food poisoning. And I was going to, his tongue was so pasty. I mean, he was so dehydrated, he couldn't pick his head up. And I said, "Go get the emergency kit." And he's like, "What are you going to do?" And I said, "I'm going to get you some fluids, buddy." "How are you going to do that?" "I'm going to start an IV." "I don't want a needle." "I don't want to give you a needle, but that's kind of the option that you have left me with here, my friend." And literally, he said to me, "When's the last time you gave somebody a needle?" I said, "About 25 years ago, but it's okay. I stayed at the Holiday Inn Express right next to the airport last night. You are in great hands." This poor kid, I swear to God, he was crying, bawling, "I don't want a needle. I'll drink water." And when we landed, they sent me another letter saying thank you, and they gave me $100 credit. So what I've realized is, if you're an employee of Delta Airlines and you pass out on an airplane, your life is worth less than a passenger.
Than a
I
passenger.
got 100. Yeah. All right. So now that I've wasted everybody's life, let's move on.
This is funny.
So Terry, go ahead and jump in and let's talk about some of this compliance stuff.
Okay. So what I'm dealing with right now, and this is with urgent care centers. And so this is kind of an interesting one. So, and I think we've mentioned it on here before, I'm not sure, but for those of you that have anything to do with urgent care, or even if you have a patient that comes in your office that you need to direct admit to the hospital. First of all, there are rules that we're following when we are documenting our services. And just because you're sending a patient to the ER or the hospital doesn't automatically make it a level 5. So you have to be careful with that. Just like somebody saying, "Well, I added a prescription, so that's automatically a level 4. No, you can't do this automatically anything. But what urgent care centers are doing lately is that they have a patient coming in, and a lot of them are turning into primary care offices that just happen to be open late. And it's really a tough thing right now. But patients are being transferred to the ER because their insurance won't pay for an ultrasound or an x-ray in a place of service 11. They'll only pay for it in a place of service 23 or 22, so hospital, outpatient, or ER. And they're saying they're billing a level 5 because they're sending to the hospital. I'm like, okay, back the train up. That's not going to fly. You can't base your leveling of your visit based on what the insurance company will or will not pay for. And so this is a huge problem right now. And I have several new, actually, urgent care centers that are saying, we're getting requests for refunds saying that these are only level 3s or level 4s. And I'm reviewing the chart. I'm like, well, they are correct. No, we sent the patient to the ER. But you sent them because you actually even documented the patient can't have an x-ray here or an ultrasound because it's not covered on their insurance. They're like, right, so we're sending them to the hospital. Any hospital visit is considered a high level. Oh my gosh. So this vicious cycle of trying to explain why this isn't true is similar to me trying to explain to a physician that refilling a prescription is not necessarily prescription drug management. So it's kind of like right now we also have a problem. I'm sure Sean has seen this on some of the things he's doing. And I know Christine has because we talked about it, where somebody puts down prescriptions refilled and then they're trying to charge a telehealth visit. Refilling prescriptions versus managing a patient's prescriptions is completely different. You can't make assumptions that these routine things that you do are just, you know, something that are necessarily either upcoding or billable. And I don't know if it's a compliance problem, but it's definitely bordering on a false claim problem. So you have to be very concerned about this.
Yeah,
we see that a lot. Oh,
go ahead, Christine.
I was going to say, we see this a lot with the annual wellness visit too, that they renew a prescription for a stable condition that they're talking about during annual wellness. They're trying to get that separate evaluation and management. You're not managing anything. There's nothing there to support that 25.
So here's what I tell people, okay? Think about what you're doing from the perspective of having to defend yourself sitting on a witness stand in a criminal or civil trial, facing down a prosecutor whose only job it is to paint you as a bad person. Okay? Seriously.
But Sean, most people don't think that'll ever happen to them. They seriously never think that they'll get an audit. I'm still getting that. Oh, that doesn't really happen, Terry. That's only in the movies.
And let me tell you something. It has been this way for years. And I've said it 100 times and I'll say it 100 more. We have entered into a new era of audits, investigations, and overzealous prosecutions. Okay? Period. Thinking that it's never going to happen to you, that's when it happens. Okay? Look, something that is routine, that is not emergent, does not mean that you increase the level of evaluation and management service, because your medical decision making has not increased because the insurance company says we don't pay for an ultrasound or an x-ray in your office. And you say, well, I'm going to send them to the emergency room to get it done. That is not medical decision making. That is you saying, well, heck, I'm not going to get paid for it, so I'm not going to spend the resources to do it here and lose money, so I'll send them to the hospital and let them deal with it. That's not a level 4. That's not a level 5. Folks, listen to me. You got to be smart about this stuff. You've got to use common sense. Paul, you look like you had something to say, or Stephanie?
Oh, I had something to say. I think that a lot of providers' offices don't really realize that you're asking somebody other than the patient to pay the bill. And they're happy to do it if you justify it to them. And that's where we get our policies, LCDs, NCDs. Here's how I want you to justify me paying the bill. And that's coming from Medicare, that's coming from the commercial payers. If we didn't have to deal with somebody else paying the bill, then this would be a one-on-one transaction. I don't feel that I should pay you $200 for today's visit. You said hi, you said bye, and out the door. Just because I purchase a policy doesn't mean that that payer is obligated to pay for everything medical. If that were the case, then this little line in my head would not exist.
Yeah, and I was going to say, I actually am having the opposite problem, Terry, where a lot of the audits I've done recently, the providers are downplaying the work that they're doing in the office. It's not an urgent care situation, it's internal medicine. But I was actually reviewing one this morning. They coded it at a level 3 with low medical decision making. When they did the entire evaluation, the workup, they ran blood tests in the office, made the determination that the patient required a transfusion, which they couldn't do in the practice. And then they got them to the ER, called the ER, discussed everything with the triage nurse, talked about differentials, talked about the treatment they determined was necessary, and that paints a much different picture. And that's kind of the way that I try to go about educating providers on that as well, because I do come across some, like Terry's explaining, where they think automatic 5. And it's one of those things too, keep in mind, we have to have free texted documentation to see any of this. So if you're a point and click provider and you like to show chest pain, refer to ER, can't really do much with that. So we've got to
Oh my God, Stephanie, that's such a great point. That is such, folks, repeat that again, Stephanie, about if you're a point and click provider. Say that one more time.
So if you say something along the lines of chest pain, refer to the ER, we really can't see what that provider's thinking. And beyond that, you know, a lot of people forget that auditors, reviewers, coders, internal, external, none of us can make a clinical determination. So we can't look at chest pain, we can't look at abdominal pain and say, oh, they're concerned about appendicitis, we need to get them to the ER. We can do none of that.
Remember, auditors and coders cannot infer anything in a medical record. Their job is to abstract information that is contained within inside the medical record to use that to help substantiate a claim that is submitted to an insurance company for processing and adjudication of payment.
Well, and I think things have gotten a little bit worse too when it comes to the 2021 guidelines, is that AMA took out of the equation the need for all of the filler on the history and exam. They didn't take out the need for it from a medical necessity standpoint. You still have to have a history and exam, but they tried to make it, you know, as patients over paperwork. You know, that was their motto. And so they said, you don't have to do this, you know, 90 point whatever exam in history. You still have to have one. But then we get into the medical decision making, which has clear guidelines on that. And I'm still seeing people or providers trying to cut corners with as auditors, you know, this is to the listeners, we as auditors, as medical professionals, and, you know, as anybody reviewing the chart, even from the payer side, I'll even throw the payer in there, you're trying to understand the total health picture on this patient based on a documented record. And if we can't see the physician's thought process as we are looking through this information, we have to basically just take what we've got and go from there. And so if we can't, because like Sean said, like everyone on the roundtable said, is that we can't infer. Otherwise, we have to query if there's a question. But I had a physician the other day. He said, well, I have the diagnosis of diabetes there, so you should know that this patient is going to take longer to heal. I go, well, first of all, I do know that because of my nursing background. I said, but you did not explain that in relationship to the procedure that you're going to do, that this individual patient is going to take longer to heal. What you did is you gave a generic statement on the risks of that surgery, like you do with every single patient that's going to have gallbladder surgery. And that's not what the question is. The question is, what is the overall risk of morbidity and mortality for this patient? And Christine, here's your shout out today. You know, so it's what is it for this patient today? It's not what is it for the entire patient population you have that has these services. And I think that's where there's still that disconnect, even though AMA has tried to make it less paperwork intensive. Physicians are still trying to get around it, and it's very frustrating.
Well, Terry, sorry, let me jump in real quick. You know, the one thing that we can all attest to that we've heard countless times is providers say, but any medical person will know what I'm talking about. And I don't think they understand that there is a shortage of neurosurgeons who want to process claims. And so we have coders, we have auditors, we have other healthcare professionals. I mean, that's the truth, though. I mean, but that are looking at these documents. So your peers
Christine's my favorite.
Your claims. Yeah, but that's what we hear over and over again. Clinically, every doctor, every dermatologist, every urologist, every urgent care knows what I'm talking about. They're not processing the claims. They're not paying the claims. Sorry, Paul.
Oh, not a problem. There are two things I want to add. With regard to the today issue, boy, is this going to come into play with the 2023 guidelines for inpatient and observation, because the habits, and I know that Scott Kraft has talked about this before on the show, with inpatient stays is just kind of reiterate information that's gone forward, and you bring in daily vitals and you bring in daily labs, and I think there's going to be a real problem with proving what you did today, and I'm already seeing signs of that in early 2023 audits. The other issue I want to put forward is that even though it's now a medically appropriate history and a medically appropriate examination, what we're dealing with is still an EMR that was built for the 1995 and 1997 guidelines. None of these guys are updating their templates in a voluntary fashion. Nobody is working with them in a definitive way to say, hey, this is what medical documentation needs to look like in your Cadillac of an EMR that your these companies and these practices and these hospitals have paid a fortune for over a period of years to try and make their medical information more sound. And it also is holding everything back from evolving EMRs into the next level, which is helping them with decision support. If you're still using old sets of templates, it's not going to be assisting.
So Paul, I want to say something real quick on that, because you raised such a great point, and it got my mind thinking about something that I was talking about in the course that I taught last week out in Arizona. Everybody now is so focused on auditing 2021 and now auditing shortly 2023 E&M services. Do not forget to include in your quarterly audits of your providers, or your biannual audits, or your annual audits. Do not forget to include a portion of those records prior to 2021, because everything that is being prosecuted right now, everything that is being investigated, everything that is being audited is still based on 95 or 97 E&M documentation guidelines if they're auditing for E&M. So ignoring those from your internal or external audits is ill-advised, because you still need to be able to identify weaknesses, vulnerabilities, liabilities, whatever you want to refer to it as, to be able to kind of, mitigate your risk of what a overpayment could potentially look like, or what indictments could be brought against your providers under, 1349 of, 31 USC. So be careful with that. That's conspiracy to commit healthcare fraud. So Paul, something that ties into the legal aspect of stuff. And then Terry, I want to finish out this discussion, because in their infinite wisdom, HHS opted to once again extend the public health emergency based on COVID-19 concerns. I have no clue as to what those COVID concerns are, but I want to get your take on the continued impact of telehealth. But before we get to that, Paul, I want to talk about legal fees. Go ahead.
Yep. So in the last 2 weeks, we've had two issues which really drive home the point of doing things proactively and not retroactively at the time you get some type of case brought against you. We have one client who has been fighting charges against them with regard to their billing, whose retainer ran out with their attorney because of the high legal fees, and now they're having to deal with a federal public defender. And then we had another client who had a $32,000 judgment against them by their state Medicaid agency, with an attorney telling them that fighting that $32,000 finding, which we determined was completely erroneous and was not looking completely at the way they bill services in that particular state's Medicaid program, the legal cost is going to be between $50,000 and $75,000, which is 2 to 2.5 times what the amount of the overpayment is. We're not talking about doing all of these things retroactively just to add to your workload. There is a very salient and very good point about doing these things proactively instead of trying to deal with them retroactively. And you have too many hands in the fire. There are going to be too many requests for help. Sean and I get a few a week now in cases such as this. And the legal fees are not getting any cheaper.
Well, I mean, we just had a brand new case surface last week where 2 different law firms had to get involved. One law firm's retainer was $75,000. The other law firm's retainer was $50,000. And then another consulting firm, not our firm, Another consulting firm was another $20,000. So if you take a look, I mean, you're talking $150,000 approximately in just retainer fees to, get the proper defense. But I love this statement made by Debbie Lupton. I really do. Having started in HIM in the mid 80s and working in compliance the past 20 plus years, I personally would like to see all the pre-filled templates go away, except for those templates with only the heading. These pre-typed templates are a nightmare, and that is where we have the downfall, thinking that every patient with diabetes is treated the same way because we are supposed to read the mind of the author as to the specific treatment of that individual patient. That is such a fantastic point. Look, I also think that the day that EMRs were forced onto providers of healthcare services was the downfall of healthcare in our country, because we got away from patient-centered care to the point and click to make sure that we captured all the required beans to be able to support a level of service, which was ridiculous. I mean, it's just ridiculous. Go ahead. So let's transition now. Our last topic of the day that I want to talk about, and I think seriously, this is so important because telehealth has become such a critical part of every single thing that transpires in a medical practice, right? Because patients, especially those who are non-ambulatory, those who don't have rides to and from the physician's office, patients who have severe anxiety, who don't want to be out in public, they have become very dependent on telehealth. And what I posted something, and I thought it was just this, inconspicuous post that I put out there, and 20,000 views later and dozens of comments and hundreds of reactions, I've realized that, oh my gosh, people are as confused about the public health emergency and, are the 1135 waivers still in effect because the federal government has extended it? What about the states that have said there is no more public health emergency? Our president, Joe Biden, has said, for all intents and purposes, the public health emergency was over in 2022. I think it was in November. So, Terry, and I agree with Christine when she says telehealth is here to stay, but what is the real impact and what is the real risk to physician practices, and what do they need to know about telehealth? Because I don't know anybody more in tune and more competent about talking about telehealth services than you, in all sincerity.
So I've been dealing with telehealth for probably 15 years before we had the PHE, obviously, and we had originating sites and distant sites and the actual former rules. We call it pre-pandemic and now post-pandemic, kind of. But I guess during the PHE, the thing you need to know today, and I have to say that because we were renewed last week for another 90 days, and they can only do it in 90-day increments. And I'm going to give a personal opinion right now, and maybe it's my professional opinion, but I think it was irresponsible to renew the PHE, because if you look at the rules of what a PHE is, it doesn't meet the definition right now. It has to be a natural disaster, an emergency that you don't know what you're doing, kind of like at the beginning of the lockdowns. We now have vaccines, we have treatments, we have, the hospitals aren't as impacted as they were. Then they went on to say, this was crazy to me, that HHS says, oh, by the way, you can treat RSV patients, so that respiratory problem that people are having. You can treat severe cases of certain flus. It became very political because we had, I kid you not, we had 19 House resolutions. We had 14, I'm reading from my list here because I kept adding to it, 14 bills that were put through or trying to put through, introduced into the Congress and the Senate, and it's just ridiculous. And it was all during the the midterms. So and it really had nothing to do with patient care, except look what I'm doing for my district. And so right now that we are in the PHE, and And we're trying to end it because Congress, in the last omnibus bill, which was passed the 11th hour, the last week of 2022, stated that the flexibilities, and I don't like the generic statement, the flexibilities will extend through 2024. Okay, let me explain what that actually means. That's not actually accurate.
Yeah, I mean, what flexibilities, Terry?
Yeah. So what actually it does extend, and they even say it, if you actually have read the 4,127 pages of the omnibus bill, which I know you all have, and I know Congress has too, of course, because they had one day to read it before they voted on it, is that it says certain services. It doesn't say all services. The other thing, and I was actually talking about this at the winter meeting last week. So Medicare came out, CMS came out in April of 2022 because they saw all the crossing state line physicians during the PHE. They said, all these physicians were coming out of retirement thinking, I don't have to leave my basement, my home. I can, see a patient. I don't have to get re-credentialed or relicensed or anything. I can just see patients if I want to in Florida, but hey, I'm in New Jersey. Well, that wasn't accurate either because the states supersede. We're the United States before, the government. If it's a government entity, then yes, they have control over that. But certain state-specific rules fall in the states. Remember, these fees that doctors pay to be licensed, to be credentialed, to be able to practice in a state, they are really expensive. And so those states don't want to lose that revenue. So anyway, right now, the telephone calls, audio only, for timed certain telephone calls, again, medically necessary. And also, I don't know if you read this in the omnibus bill. I did. I've actually gotten through 2,000 pages, believe me. It'll put you to sleep. But it had said that if the audio and video isn't available, did you know that? So only if it's not available. You can't use it just because that's the preference of the patient, only if the audio and video isn't available. That's same with mental health. And for mental health services, which some are permanent, you have to use a modifier for them as well, FQ. So that was the one thing. But the other thing is that we have so many states. Florida in 2021 at the end took off theirs. California, and that's where I'm in. I was actually surprised. And you actually can find it on the last our article I did. They actually have it on their website that says that it was ended in some of the services were ended in 2021. But as a rule, for Medicare patients, the audio services for the phone calls only, those are still available. Medicare patients, you have to look at the state for other things. You can't cross state lines in certain states. I know that Alabama just took it off with their new governor. I know that in what was the other one? Texas, they just took it off. They said, it's time just to be, our lives are back to normal. Let's not do that. As far as audio and video, this is the biggest thing I still see. I am auditing records left and right on this. So many practices think that they can bill for that for insequential services, for things that non-medically necessary services. If you didn't do it before pandemic, don't do it now. That's the biggest thing I can say to that. If you didn't bill to call a patient to give them test results, you shouldn't be doing it now. If you didn't bill to refill a prescription, you shouldn't be doing it now. These services have to be patient initiated. The other thing is that read your contracts, because we're in contracting season from last November till now. I've seen several Blue Cross Blue Shield contracts, an Aetna policy, another United Healthcare policy that had said that they don't cover for audio only anymore. There's a couple of them that said that they only will be limited on how many audio and video. My personal insurance says, yes, you have VIP coverage, which is telehealth, but I have to use their panel doctors. I can't even see my physician. So you need to know, the coverage policies out there, because just because the PHE still exists, really what this is about is trying to slide in budgetary payments for things that aren't paid when there's no PHE. For example, Medicaid patients. Medicaid patients are covered under the PHE and you can't disenroll them for any reason. You can't disenroll them, even if they've gone back to work. We've got people in California and Arizona and in Utah that have double coverage right now. You want to make my head spin around. And I'm like, wait, what? They said, yeah, they've got work insurance and they've got Medicaid secondary.
State insurance. That's
right. Are
right.
you kidding me? I mean, it is costing so much money to keep the PHE in place. So on April 5th, NAMIS is having that week is having their conference, and myself and Attorney Brianna Santoli, we're actually presenting on the state of the PHE. It should be winding down by then, but a date to keep in mind, Sean, and then I'll throw it back to you, is that the 60-day notice is supposed to come on February 11th. And so that means that it will end on April 11th. We hope that is going to happen. If it doesn't come,
I have a
they're going to
feeling.
say no.
Yeah, I have a feeling with the change in congressional leadership that there will be mounting pressure because of now what is becoming the launched investigations into the origins of, this whole COVID-19. Listen,
well, they just issued a warning as far as some things, some medically contraindications.
Right.
So
that's right. I think it's going to be a very interesting next few weeks to see how this thing plays out. I am expecting that this new Congress will put a lot of pressure onto the Secretary of Health and Human Services to issue the proper notice to end the public health emergency on February 11th.
Let me just say one more thing before you hang up.
Go ahead.
One of the things that you need to realize, our current HHS secretary and our previous one, they are not physicians. They are not physicians. And so talk to your congressmen, talk to your reps, get this, finally ended. And so we can just move on.
Paul, go ahead, please.
I do have one follow-up question. And this is a question that I tend to get a lot from practices in our NAMUS Ask the Auditor forum actually comes up a lot. What are the odds of going back to pre-pandemic telehealth rules after this public health emergency ends?
I think to a point they will, because they can't, on audio only, those have to go away. They don't have, Congress doesn't have the authority to extend audio only. We will have a G code, G2252 for 11 to 20 minutes, but they can't keep opening the phone call codes because those aren't, and I'll quote what they said, those aren't consistent with an in-person visit. They're not analogous to an in-person visit. No. So that's the one thing I know has to go away.
Yeah. Well, I know that quite a few codes that are on the telehealth list are listed as good to go, for 90 days after the declaration of the end of the public health emergency, and then they're going to go in the ether. My biggest concern is the originating site, transmitting site stuff is going to come back.
Well, the other thing that's going to happen, and this actually came out, this is where people have to do their due diligence across. Sorry, Sean, but this is the one biggest thing is the Office of Civil Rights came out and said last week when they extended the PHE, I don't know if you guys saw this, they said, okay, this is extended, but once the PHE ends, we are not part of through 2024 to be able to use Skype or FaceTime or devices that are not HIPAA secured. And people are going to be like, wait, what? I can't tell you how many audits I do on telehealth services where they're using FaceTime. They're not using their EMR secured sites. So I think that's going to change a lot of the platform because practices haven't bought into telehealth completely. They've allowed patients to use their smartphone. And so there's no really record, if you will, of that visit. And that's going to change a lot, I think.
And that was never part of the 1135 anyway. That was OCR saying, okay, we're going to do this.
Yeah.
Until you get your HIPAA compliant software in place, you can do that. Just, and I don't think it was ever intended to be a long-term solution.
No, it was in the FAQs for fee for service. That was it. And it just said, just during this temporary situation, will not violate you for having that platform.
Yep. All right. So listen,
Oh, I was going to say, I was slapstick. I wonder how that's going to affect a lot of practices' Yelp reviews when they can't do telehealth anymore.
Ignore your Yelp reviews. People are either metaphysically thrilled or metaphysically hate you. Nobody signs on to say my experience was adequate and met all all of
you
my
don't
needs,
have
and
wine
I'm giving you a 3.
You're not serving wine in the lobby, so we don't like you. Yeah, exactly.
Yeah.
All right. So look, before everybody starts to log off out there, Terry and I will be back for our hashtag Terry Tuesday tomorrow. Jordan Johnson will be sitting down with me for our J Squared Data Analytics and the Business of Medicine on Wednesday. Thursday, I ain't doing anything because I'm going to be in Florida. Please pray for me and the people on my plane that nobody needs my medical assistance on that flight on whatever day that is. And then Friday is our first legal roundtable at 11 a.m. Robert Lyles, Ronald Chapman, and Colin Callahan are going to be joining me for an amazing panel. We're going to be talking about the proposed change to the language for the 60-day rule. We're going to be talking about now post-Ruan and prosecutorial misconduct. And we're going to be talking about the potential ruling from the Supreme Court on the scienter standard and what that means and how defense counsel can actually argue that against the prosecutor. So unbelievable. The last thing that I want to say is starting next Monday, our roundtable will be at 4 p.m. Eastern Standard Time live. 4 p.m. Eastern Standard Time live. That is 3 Central, and that is 1 o'clock Pacific time. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care.